Okay, well, welcome back, everyone. Hope you had time to stretch and hydrate again. So our next presentation will be Achieving Diabetes Health Equity, Evidence, Challenges, Opportunities, and Resources, presented by Lorena Drago. And
Hello, good afternoon, and thank you for being here today for this, the last presentation of the afternoon. I will be here and I am going to turn off the camera in a few minutes, but let me just go over the objectives of this presentation with you. Here is my bio, and let me move on to the objectives. So I will be defining the concept of health equity, emphasizing on the importance of equal access, and also explaining the various social determinants of health and how they influence the individual outcomes, and how to apply those concepts of health equity and use the data and evidence to identify and prioritize the health needs and the gaps. So what is health equity? It is the state that in which everyone has a fair and just opportunity to attain their highest level of health. Oops, sorry. Let me just go back. So here, what we have is some of the barriers to health equity. And people from some racial and ethnic minority groups exhibit health disparities. Individuals from communities or racial and ethnic groups such as Blacks, Hispanic, Asians, American Indians, and Alaska Natives have a higher prevalence of type 2 diabetes. In the United States, the average life expectancy among Black and or African Americans is 4 years lower than that of white persons. Let's take a look at, for example, persons of the LGBTQ community may experience stigma and discrimination, which may result in health inequities. When it comes to age, it's a biological factor that may accelerate disease and also disability, and that will be a factor for health inequities. When it comes to health inequities, they also arise for individuals with disabilities, as they may also face stigma, they may also face discrimination, poverty, and also exclusion from employment. When it comes to geographic location, we may see differences in urban, rural environments in which there may not be access to certain foods or healthcare access, transportation, etc. And later we are going to talk about how educational background as well as economic status may exacerbate health inequities. And that might be other barriers and what we can do about it. So let's move on to this other slide. And I wanted to give you an example of some of the barriers. And this was a conversation that I had with a colleague. And my colleague works in Phoenix, Arizona. And she has she had a consultation. She works in a hospital, and she had a consult. She's a registered dietitian like me, and she had a consultation with a patient who was Hispanic. And the first thing that she said was, I am not Mexican. I am Puerto Rican. Now, what does that mean? Now, the patient was English speaking, so language was not a barrier. So what would you do, and what does that mean when the patient said that to her? So the first thing, I started laughing. You know, we were in Houston when this happened, and we were attending the conference, the Association of Diabetes Care and Education Specialists conference this past August, and we both started laughing. And then my question to you is, what cultural barriers has this patient experienced in the past? What do you think has happened to this patient? So I'm going to ask you to, if you can please write down in the chat box, what do you think that was the first thing she said when my friend and colleague entered the room, and it was the first thing she said when, hi, how are you? My name is Yafi, and I am your dietitian. What do you think she said? I am not Mexican, I am Puerto Rican. That was the first thing that she said. What do you think she meant by that? So negative encounters in the past, she was stereotyped. People assume that she eats tortillas, rice, and beans. Okay. Assumptions based on culture. Okay. Assumptions have been made based on her appearance before. Okay. So let me see if someone else is typing more things. Okay. So let me tell you, let me go on and share more things with you. So what health disparities can this create, and how can you mitigate the cultural health disparities? So let me share with you what this means. It's more specifically with the menu. And that is because there is a very significant difference between foods that are Mexican and foods that are Puerto Rican. So that was the first difference. So my friend Yafi knows that I talk a lot about cultural competent care, and most specifically about the different types of foods and culture among the different Hispanic subgroups in the United States. And that food and dishes and meals are not the same, including in Mexico. So foods from the north of Mexico are not going to be the same as food from Oaxaca, Mexico, from the coast of Mexico, etc. And they are very different when they are from Mexico and the Caribbean. So, for example, here we have a Mexican menu, a Puerto Rican menu. So how do we close the gap? And that is how I am going to structure this presentation today. We're going to look at the health disparities, and we are going to also look at what those health disparities may cause and how can we close the gap. So here we have tortillas, which are the round disc that are the base of most Mexican food, which are not consumed in the Puerto Rican diet. What you mostly see in the Puerto Rican diet will be bread, different kinds of bread. So here we have tortilla, which is ubiquitous, whether it's corn or flour, and you don't have tortillas. And that was the second statement from this patient, which was, I don't eat tortillas. So it's the bread. The other thing is beans are consumed in both cultures, but how the beans are prepared and are consumed are completely different. Refried beans are not eaten in Puerto Rican culture. Here, beans are eaten, but they're never refried. They are stewed. Second, we have tamales, as you can see here, and they are made with corn masa. Puerto Ricans eat pasteles, and they are made with either cassava flour, with plantain flour, or root vegetables. Mexicans eat salsa that may be made with tomatillos, and they are made with onions, or they are made, and Puerto Ricans do not eat salsa. They season their foods with garlic and onions and cilantro and peppers, and it is not spicy. Puerto Ricans do not eat spicy food. They eat well-seasoned foods, but not spicy. So how do you close the gap when you're talking about food and nutrition and you don't know what foods are eaten? So then that's when you have to ask. I know Puerto Rican foods are not the same as Mexican foods, even if you may not know the difference. Tell me about the foods that you eat. Another question is, what are your favorite ones? How do you prepare them? And in Mexico, this is called this. How is this called differently in Puerto Rico? And then, how do you prepare them? Tell me about the foods that you eat. And then another thing you can do is find the resources so that you get a general idea of what are some of the traditional foods in that country or in that region. That's how you close the gap, by asking the right questions, even if you don't know. So let's move on. So here is the barrier, the cultural knowledge about dietary practices. And this could be with any other ethnic, or it could be about religious practices that involve foods. It could be about spiritual practices that involve foods, or any other kind of cultural knowledge about dietary practices. If you are not knowledgeable about it, what health disparities can it possibly create? Well, if someone doesn't know, it could create hyperglycemia, elevation in A1C. If someone provides you with something that it's generic, recommendations that are generic, then what happens is that that individual is going to then ingest the foods because they don't have the knowledge, because it's not written in the literature, the handouts that you're providing, and that may occur. And how do you close the gap? Is by providing the appropriate culturally competent nutrition and care. So let's move on. Now to the social determinants of care, and perhaps you have seen this diagram before about the 5 pillars of social determinants of care and what do they mean. And we're going to take a deep dive into each and every one of them. How do they impact and how can we close the gap, and what resources are available for you in your practice so that you can incorporate them and use them to help your patients in your own practices. So first, the definition, the non-medical factors that influence health outcomes. So this is where people live, where they are born, where they grow, where they work, where they live, where they age. There are other factors that may influence the health outcomes, and they are not limited to economic policies, the political systems, the climate change, social norms. So if you are born in the city, in a hospital where there may be more options for someone who's uninsured, like for example, I live in New York, there are more options for someone who lives in New York City and versus someone who lives in a rural area, the options may be more limited. Someone that grows up in public housing, in an apartment, or in a house, depending on where you're growing up, if there is more, better air or access to clean water or electricity, indoor plumbing. Where do you work? Do you work in a place where you have access to breaks? Do you have health insurance through your employer? Do you have days off? Do you have insurance where you have access to medication or dental health? Do you live in a safe home? Do you have access to healthy food? Do you live alone? Do you have family or friends that support you or help you, or access to transportation? Or many times, can you attend your doctor? Sometimes when I was working in New York City, there was transportation, but many times there were many people that worked and were not able to take time off work to attend diabetes self-management and education classes. So it was available, but they weren't able to attend it because they had to work. Do you understand your doctor's instructions? So there was the issue with sometimes language and sometimes with health literacy. And we're going to talk about the health literacy and how to bridge the gap. Or do you understand how to take medication or your blood glucose value? So all these factors that I just mentioned are part of this social determinants of health. And I wanted to go into those very specific elements because I know that we hear about the social determinants of health and we understand at a higher level what they are. But then when we bring it down into the more specific levels, then we really understand how those barriers can really have an impact on our health. So let's start with the economic stability. 1 in 10 people in the United States lives in poverty, And many individuals cannot afford things like healthy foods, healthcare, and housing. So let's look at, this is from the CDC, and how does it impact the prevalence of diabetes in USA adults 18 and older. And here we see that the individuals that have that live in poverty have a higher prevalence of diabetes than individuals that do not. So let's take a look here at the first row and see the percentage of individuals that live at a higher poverty level. The percentage is 14.1 compared with individuals that do not live in poverty. So here we see the relationship. So let's take a look at here. So access to also healthy foods, food insecurity. So what is the health? What does that cause? What kind of health disparity? It could be overweight or obesity, or it could be underweight. Sometimes it could be eating disorders or disordered eating. So it could be both sides of the spectrum. It could cause hyperglycemia or hypoglycemia. That could lead to hospitalization, high cost of utilization if you're using the ER. Sometimes there could be food medication and monitoring trade-offs because we have to meet our basic needs. So if there is no money to purchase food, to purchase food, then the medication will not be purchased because food will be the basic need. And then there will be diabetes distress. So these are some of the barriers that will cause health disparities when there is food insecurity and access to healthy foods. So how do we close the gap? First of all, we need to identify if there is food insecurity. And if there is food insecurity, then we can do this by using the Hunger Vital Sign screening tool. And then we need to have the resources available so that we can make referrals. And let me show you how to do that if you're not familiar with these resources. So what I wanted to show you is that the average person, when it comes to SNAP, and that is the nutrition program, that food insecurity, I didn't define it and I would like to define it now, is the lack of consistent access to food. And I would like to say that about 34 million Americans in 2021 had food insecurity. And about 20% of people with diabetes also had food insecurity. And that was according to feedingamerica.org. For individuals, the food stamp average, just to give you some statistics, food stamp average as of April of 2023 per person was $343 per household. Now, this is not the national level because it changes based on what state you live in. So New York is a very expensive place to live. So that for a household in New York is $212. But if you live in Oklahoma, the average amount is $127. So the average for SNAP, which is the nutrition program, was $181.72. Now WIC, which is the Women, Infants, and Children program, which covers women that are pregnant, postpartums, infants, and children up until the age of 5, serves only 50% of those who are eligible. Now, when it comes to the food stamp program, families are allowed to buy breads, meats, poultry, fish, fruits, vegetables, dairy, including ice cream, snack foods, etc., and even soft drinks. And this figure of 50%, unfortunately, has been a steady figure for many, many years. I want to, if you have not seen this before, this is a good tool to include in your assessment, whether you work in an outpatient clinic, inpatient clinic, in a community program. It's called, this is the Hunger Vital Signs Screening Tool. This can help you assess whether a patient or the family has food insecurity. And the question is, within the past 12 months, we worried whether our food would run out before we got money to buy more. And within the past 12 months, the food we bought just didn't last and we didn't have money to get more. This tool has a 97% sensitivity and 83% specificity. And the good thing is that it only takes 1 minute to complete. And I don't know what happened to my slides. Stephen, if you can assist.
Celia, just hold on. We'll look into this.
So sorry about that, everyone. I'm going to begin sharing again. I have a few internet issues here. And sorry about that, Lorena.
It's okay.
Let's see if this, here we go. And I apologize for that. I think
Okay.
everyone should.
Yes, I just want to say that this tool, not only does it take 1 minute to complete, but the tool is available in Spanish, as well as, yes, it's available in Spanish. That's what I wanted to say. So in this was a survey conducted by Humana in partnership with the University of California in 2000, San Diego in 2019. The individuals that were surveyed were Medicare Advantage beneficiaries with type 2 diabetes, and it was 21,000 of them. What I wanted to share with you was that they reported at least one social determinant of health, and almost 57% reported one social determinant of health, which is larger than the proportion of Medicare Advantage beneficiaries that did not have diabetes. The largest one was financial strain, and the second was food insecurity. And what I wanted to share with you, that the food insecurity was linked to higher acute care utilization, higher rates of emergency department visit, inpatient encounters, and avoidable hospitalizations. So this confirms some of the health inequities that I had shared with you before. Of course, this is just one sample, but we are talking about 21,000 individuals that were surveyed. So I feel that it is very important to have the food insecurity question. It's a very simple 1-minute tool that can actually identify if there is food insecurity. So now you have the food insecurity question, you have included it in your assessment, and now you identify that there is a problem. So what can you do? So here is a resource that I have for you. And one of the resources in diabetes.org, community connection, you can go here, and if you discover that your patient responds yes to one of those two questions or both, you can enter the patient's zip code. Once you do that, and you can find all of these resources that are available. So once you do that, you can click where it says here. So what I did was just to show you so that you can have an idea of what does it look like in real life. I entered a zip code, and it shows you things such as food banks, SNAP, which is food stamps if someone needs food stamps, or senior centers, or if they are medically tailored meals, which have the potential to result in $1 billion, saved, and other places in this patient's community that can assist. And there are other things that individual can access right here. So this is a great resource that you can find quickly available, so that you can use it. So I'm going to go back just in case that you want to look at it again, and that is in the, oops, I think I just, let me go back. Okay, here it is. In diabetes.org, and it's the community connection, and that's where you enter the person's zip code. Okay, so we talked about, like I said, all the resources that are important, understanding the health inequities, but more important is how do we as diabetes educators, health professionals, help individuals identifying what are the barriers, what are some of the health inequities, and also bridging the gaps. So here we have people with higher levels of educations are more likely to be healthier and live longer. And so here is another graphic that shows, just as I showed you the one with income. This is also from the CDC that shows that individuals that have more education, again from 2018, 2019, the percentage of US adults 18 and older diagnosed with diabetes. And then you can see very similar numbers that we have with education as well as with income. So there is something else that I wanted to talk about that is important, and that is health literacy. So health literacy is the ability to understand health information and put it into practice. And that is my own definition, my simple definition of health literacy. So the National Assessment of Adult Literacy demonstrated that certain racial and ethnic groups, individuals that of certain age, older adults, have lowest average health literacy scores of all racial and ethnic groups, followed by Black, American Indian, Alaska Native adults, and individuals that also have limited English proficiency also have barriers. And that has an impact on, can have impacts on health outcomes. So I want to give you a story. I think that stories exemplify what could happen. So here I have the story of the child, the cereal, and hyperglycemia. This is a story that happened to me when I had a pediatrician refer a patient, a child with type 1 diabetes, and her mom, because she did not understand why her child kept having, her A1C was high, blood glucose was high, and she called me and said, Lorena, can you please see this patient? I really don't understand what is happening. She is coming to me with a journal. She's writing what she is giving her child, and she's counting carbs, and I just don't understand why there is hyperglycemia. She seems to be doing everything right. So I said, okay, not a problem. So she was giving her child cereal in the morning, and as a dietitian, I usually have this measuring cups, as many dietitians and diabetes educators do. 1/4, 1/3, and half a cup and 1 cup measuring cups. She had written that she was giving her child 2/3 of a cup of cereal, 1 cup of milk, and she was writing down the amount of carbohydrate, and she was adding everything. Everything looked right. So then I asked her what measuring cups was she using to measure 2/3 of a cup, just like what it says on the label that you see in front of you. So she shows me the 1 cup that it's here, and then she shows me the 1/3 of a cup. I asked her again, so you're giving your child what size, how much? And she says 2/3 of a cup. And I said, and which cup are you using? She shows me again the 1 cup, and she shows me the 1/3 of a cup. And I said, okay, that's what you're using. And then I said, and milk, and how much milk are you using? And she says, sometimes 1 cup, but sometimes I use less. Sometimes I use 2/3 of a cup too. And I said, and when you use 2/3 of a cup, what do you use? She shows me again the 1/3, and she shows me the 1 cup. And then I realized what she was doing. She thought that 2/3 of a cup was 1 cup plus 1/3 equals 2/3 of a cup. So the problem here was numeracy, lack of arithmetic, was not understanding fractions. So this was the problem. Because she didn't understand fractions, she did not understand that 2/3 of a cup was not 1 cup plus 1/3. 1/3 of a cup was 2 1/3 or less than 1 cup. So that first session was for me to teach arithmetic and teach her that when it says 2/3 of a cup, this is what she needed to use with her measuring cups. So many times when individuals are taught to use the nutrition labels, individuals say they know how to use it because we assume that individuals know numeracy and that they know arithmetic and that they know fractions. But the majority of individuals do not. So then what do we do? So these are the consequences of limited health literacy, and then I will show you what we need to do. In this particular study, 70% of patients with low literacy read at below 6th grade level, but reading is not an issue as much as numeracy. And there's a lot of numeracy when it comes to diabetes and diabetes management. Many people did not know what take 2 tablets by mouth twice daily means. So how many, and I want you to just tell me in the chat, how many individuals do you think, what percentage in this study understood what take 2 tablets by mouth twice daily? What percentage do you think understood the directions? Oops, it was 35%. So that is pretty scary. So let's take a look at individuals' diabetes, A1C, and health literacy. So what I wanted to show you from this particular study is A1C less than 7.2% and percentage of patients with A1C equal to or higher than 9.5%. Individuals that had adequate health literacy, 33% had A1C equal to or less than 7.2%. Here, individuals that had inadequate health literacy, 30% compared to 20% had A1C lower or higher than 9.5%. And then we can see how those things can really hinder if you don't know how to take your medication, if you don't know how to weigh things, if you don't know how to perform certain functions when it comes to managing your diabetes. So in this particular health literacy and glycemic management, the relationship between health literacy and A1C was explored in 13 studies, 2 cross-sectional and 1 longitudinal. And some showed that higher levels of health literacy were associated with better glycemic management. And mostly observed in studies that adjusted for age, sex, race, education, and treatment plan. And some of them were inconsistent, and the evidence was rated to be insufficient. So it wasn't really, all of them were not comparing exactly the same thing. And I think that that's what the evidence was rated insufficient. However, I do feel that there are certain ways, there are certain things that it is clear that when there is lack of understanding, when there is lack of an ability to add, subtract, divide, it will hinder. But when the studies are not comparing the same thing, definitely I can also see where the data will be insufficient as well. So low health literacy and low numeracy may result in hyperglycemia, hypoglycemia, hospitalization in sometimes, high cost utilization, and report in poor health status. How do we close the gap when those things occur? I would say definitely use the teach back method. The teach back method is a way to, not for the patient to be tested, but for you to ensure that you have taught something correctly. That's basically what it is. And I provided you with those 2 resources that really can help you become an expert in teach back. And 2 ways to do this, I will show you how to do this, is, again, it's not for you to test the patient, but it's a way for you, for us, the health provider, to ensure that you have provided the information in a clear way. So 2 ways to do it in very simple ways is, at the end of you teaching something, is to ask the patient to show you or tell you what you just said. is a way for them to explain it back to you. And sometimes what I say is I put the onus on me. I say, I know that I gave you a lot of information or complex information. And I want to make sure that I taught it in a clear way. If you were to share this with your relative, can you say this in your own words just to make sure I explained it correctly? And then ask them to share it in their own words. Or if it's something that I taught, whether it's a glucose meter or a pump, anything, then break it and say, can you show me how you're going to set this up? Can you show me how you're going to put this on? And then see if they remember correctly. So here is something using the food label as teach back. So not just to tell someone, make sure you read the food label because you don't know what they know. So let me show you. Tell me, what are 2 servings of masa? And then you want to make sure that they tell you. So what are the answers? 1/4 cup is 1 serving, but what are 2 servings? So they can tell you 1/2 cup, or if they are measuring it in grams, they can tell you 60 grams. Either one of them is correct. If they're looking at you like, I have no clue what to say, you know right away that they have no clue. And tell me, how many grams of carbs will you have if you have 2 servings of masa? Then they have to tell you 46. That's it. That's the answer. If they say to you, I'm going to have 16%, you know that they don't know what to do. And if they're using insulin and they have a 1-to-10 ratio, then they need to know. Of course, if they're using, if they have an app and that app is providing them or a calculator, that's fine. But somewhere along the line, they have to be able to tell you 4.6 units, etc. So you see here is where those calculations, that math skill, that numeracy is important. So I think that that's where you need to test that numeracy skill with your patient. That's where you need, if you're teaching the food label, don't just say, make sure you read the label, make sure you read those carbs, you check the carb, because if they're using this, or if they're eating this, you don't know what they're doing. You need to do that teach back before they leave. Okay, so moving along with the other determinants of health, healthcare access and quality. Many people in the United States do not get the healthcare services they need. What does that mean? It means that about 1 in 10 people don't have health insurance, and that people without health insurance most likely may not have a primary care provider, may not be able to afford healthcare services such as diabetes self-management, education services and may not be able to afford certain medications. So strategies to increase insurance coverage are really critical to make sure that more people get important healthcare services and sometimes even preventive care and treatment for chronic illnesses. For example, we're talking about now we have vaccines. Individuals may not get the referrals that they need for certain screenings like cancer screenings, mammograms, vaccinations, etc. Sometimes they may live away from healthcare providers, etc. So all those things are part of that healthcare access and also the quality of healthcare services that they might need, and they may forego of those services that result in those healthcare inequities. So again, sometimes it may be lack of health insurance, or sometimes individuals may be underinsured. They may have a very high copayment, so they may not go to the doctor until they are sick. They may not have access to certain medications, so they may not take them. Sometimes they may have certain health beliefs about certain medications or certain attitudes about certain medications or certain communications that may involve their own culture. So how does that result? How does that look into the health disparities? Again, it could be hyper or hypoglycemia, more either hospitalization or high cost utilization. They may not feel well, and again, less likely to use preventive health services, which again may result in hospitalization and poor health status. So how can we close the gap as health professionals? We need to use assessment tools, use the resources that exist. Some of them are the ones that I had shown you before, going to diabetes.org and using those resources and then provide the referrals. So what are some of the assessment tools that we can utilize when we have that patient, when we do see that patient, whether it's outpatient, whether that patient is in the hospital, so that we can have that patient there and then make that assessment. So I want to introduce you to this tool that I have found useful, and it's a Kaiser Permanente Your Current Life Situation tool. And this survey was developed to capture a wide range of social and economic needs, including the person's living situation, the housing, the food, the utilities, their childcare, their debts, their medical needs, transportation, stress, even social isolation. So the resource is there, but I wanted to give you a snapshot of the tools, the questions that are asked to capture everything. This may be familiar to some of you, and it may not be as familiar, but I know that I have been in many times that I have been in the medical system, whether it's for a procedure that I have gone through. I have been asked these questions, and I feel happy when I have been asked these questions, because I knew immediately that those were assessment tools for social determinants of health. And some of them have encompassed the hunger vital tool, and some of them include which of the following would you like to receive help with at this time? And look at all the things that are listed here: dental service, vision services, applying for public health benefits, legal issues, employment. So I'm not going to go through all of them: housing, transportation, and social distress, etc. So these are many different questions that you can access through this particular tool. And I am going to show you another tool, another assessment tool. And here, there are many more that you can access. And here you can access even more tools. So if you can just, let me give you the URL. It's right in here. It's an extensive list of tools and resources that you can access. So the one that I showed you was the Kaiser Permanente, the one that is listed here, Kaiser Permanente. But here you can have any tool that you need. You don't need them all, but you can find the one that best suits the needs of your office, clinic, community, and so that you can assist your patients with their needs. So you can take a snapshot of this particular URL. So I wanted to touch about cultural health beliefs simply because of some of the issues that may present when it comes to medications. I wanted to touch base on this particular study, and this is just because I wanted to emphasize about issues with medications when it comes to certain groups. And one of them is when it comes to challenges with Hispanic Latinos in insulin initiation. Now, this may not occur with every Hispanic subgroup. Just like I mentioned with that first example with Hispanic Latinos, my first example with the Mexican and Puerto Rican, this is not homogeneous with all the Hispanic subgroups. But I do want to say that when it comes to insulin, look at the side effects of insulin are of major concern with certain Hispanic subgroup, especially when it comes to dependency. I have seen this concern mostly with Mexican patients. And because of that, this is something that I have included in my own assessment when I counsel some Hispanic patients, simply because I add the question, are you concerned with the side effects and dependency when initiating insulin? Simply because most often than not, the answer is yes. And I need to have that conversation so that I can address some of those concerns. And I think it's important for many people to have that conversation, because this can create those disparities, and you need to include those myths and misconceptions during the conversation. I also want to address, to also show this particular slide. It's a little old, but I really also wanted to emphasize that this looks at 3 different groups, Latinos, African Americans, and whites. And while expenses are of concern when it comes to Latino patients, when it looks at side effects, look at the difference of side effects when it comes to medication, and look at dependency when it comes to medications, when it comes to Latino patients. Now, there's also a concern with African American patients as well when it comes to side effects. So I think it is very important when it comes to medications that we also ask that question to our patients. If are you concerned about side effects and dependency of your diabetes medications, so that we can address it, because there may be a problem of not taking medications as prescribed, and we may not be addressing that. And that also may definitely affect outcomes. So moving on to neighborhood and built environment, we are talking about violence. It could be unsafe air. We have seen in the news water and other health and safety risks. Many times, racial and ethnic minorities and people with low incomes are more likely to live in places that have these risks. So what are some of the things that we can do? So of course, unsafe housing, lack of unreliable use of transportation. These are some of the health disparities: lack of transportation, utility insecurity, housing insecurity, all linked to diabetes medication. Taking a key element of clinical quality. So it's, and lack of transportation was also linked to increase emergency room visits. And this was also part of that survey that I had shared with you in the previous slide with Humana and Medicare patients with type 2 diabetes, the one with that resulted in at least one social determinant of health. So what can we do to close the gap? Again, we need to first know if there is lack of unreliable transportation, because we see, at least in this particular survey, it was linked to lower diabetes medication, taking diabetes medication, and then provide the resource and the referrals for the patient using one of those tools that I had shared with you earlier. And then we are almost finalizing this, and I am going to close it with social and community context. And that is people's relationships and interactions with family, friends, co-workers, and community members can have a major impact on their health and well-being. And what does that mean? That means is the value of social integration, the value of community, the value of support. And feeling of loneliness, anxiety, depression, diabetes, burnout, diabetes, distress. And the experience of loneliness was linked to lower diabetes medication adherence or taking diabetes medication, a key element of clinical quality. An experience of loneliness was also linked to increased emergency room visits. So it's not just about health literacy, it's not just about our education or poverty, but also about how we feel. How we feel if we don't feel well. We may not take our medication. We feel so unwell that we may end up in the emergency room. So again, we need to assess how we feel, and I think that many of us do that with the PH to Q. You know, how do you feel? The resources and the referrals are extremely important. And again, this was also validated in that Humana resource. So that's extremely important. And I just wanted to share something with you about the importance of social integration, the importance of community, the importance of family. And when I say family, I'm talking about togetherness, whether it's our own family or friends and community. It doesn't have to be the family that we are born with, but the family that we choose through our friends and our community. And this has nothing to do with diabetes, but this has to do with community. And I wanted to show you about the ethnic differences in survival among lung cancer patients. And this was a meta-analysis of 29 studies, shows that Hispanics exhibit similar or better survival rates in the context of lung patients relatives to non-Hispanic whites, despite a substantially worse risk factor profiling, highlighting the Hispanic health paradox. And I'll tell you why I wanted to show you this study. So when socioeconomic, social related variables were controlled, disparities for Hispanics reduced to zero, or even reduced a disadvantage to an advantage. And foreign-born Hispanics experienced some of the strongest advantages. Some studies showed women experienced higher survival rates than men, and Hispanic lung cancer patients more likely to be diagnosed at a larger stage. Odds of survival remain comparable or advantageous. And the conclusions in this study, and this is not the only study, was that not only was the difference in diets that may contribute to resilience, but unlikely to drive lung cancer mortality rates difference, but that the social integration remains a strong determinant of health outcomes and mortality. So cultural values of collectivism, familismo, which means the stronger family ties and interpersonal harmony, simpatia, may explain better survival rates. So I just wanted to show you that despite many things that were not working in favor, that sometimes that social integration that I was talking about helped these individuals have a better outcome. So let's not put aside the importance of that social integration, the value of collectivism, social care, and integration when it comes to health. And now, what questions do you have?
Thank you, Lorena, for an excellent presentation. And we will now take a moment for questions. Invite everyone. If you do have a question for Lorena, please type the question in the chat box so that it might be answered.
I did see one question come in which says, can you please re-show the slide on the surveys?
On the surveys, sure. I will show the assessment tool slide. I just want to make sure that the person that wanted the survey can take a snapshot, and I will show the other one. This is the assessment tool slide. And there was another one that I will show in case you want to take a snapshot. This is the Kaiser Permanente. And then this was the other one. Let me show the URL. And someone had a comment about what she found helpful. Getting patients to understand the role of medication is giving them an overview of diabetes course, discussing common side effects, risks, and benefits. Sometimes what I have done, just to make it very, very simple, is since I wear glasses all the time. That's the first thing I do when I wake up and the last thing that I remove when I go to bed. In a very simplistic way, what I do is I remove, I tell them that when it comes to insulin, is that our bodies are not producing insulin the way that it's supposed to. So we have to replace it because the body no longer does it. So when it comes to my glasses, my eyes are no longer able to see the way it's supposed to. Therefore, the glasses are doing what my eyes can no longer do. So that's why I have to wear the glasses. So am I dependent on my glasses? In a way, yes. am I dependent on my glasses? So it's not a terrible dependency because it helps me to drive, to walk, to watch TV. So using insulin is just replacing what your organ is unable to do. But it's not the same dependency as being dependent on a drug. It's completely different. And then most people get it. I think the fear is being dependent on a drug. It's not the same as a drug.
Are there any other questions that you all have for Lorena? There is the comment, Lorena, that this person also uses for bolus insulin comparison to automatic transmission versus automatic transmission. So
Yes, yes, I see that. I'm reading the comments.
yes.
Yes, thank you. Yeah. And I also say that our bodies regularly produce insulin throughout the day, but then when the body is not doing it, then we have to adjust it in a way that it does it throughout the day, and then a little bit more every time that we eat, or every time that the blood sugar becomes elevated. So that's why it's not exactly the same way. So that's why we have to use the insulin in that particular way. I see mostly people with type 2 diabetes, and then later on they are either on basal and then basal and prandial. So the explanation is a little bit different than someone that has type 1. Someone with type 1, they already know, so the explanation doesn't have to be. Someone with type 2 that starts insulin, those are the ones that I have to go into a little bit more in-depth discussion and allay the fears, because they're going into that change. So that's when I have to start with a different explanation. So everyone is different, and we tailor the communication to age, education level, literacy levels, etc. So as everyone knows who's here, you know that no two individuals are alike, and we all strive to be patient-centered and try to find the right analogy for the right patient.
Very well said, Lorena. If there are no more questions, we will go on and turn it back over to Steve.
Thank you so much, Daniel. Thank you so much, Lorena,